بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the last lecture in the sector of spinal imaging, and it will deal with imaging of the spinal neoplasms. Actually, I will handle this topic on two separate parts because it is relatively long. So I will discuss the spinal neoplasms concerning or considering these four items. Number one, the tumors arising from the vertebral column, then tumors inside the spinal canal, in the epidural space, in the subdural space, as well as inside the substance of the cord. In the first part of this lecture, I will handle the first two issues, osseous pathology and epidural lesions. Actually, you know that the spine is one of the sectors in the human body that are prone to many of the bone tumors. And you remember from the lecture of bone tumors, I handled so many of these examples, and I give some examples for cases including most of the benign and malignant lesions seen all over the skeleton. Then in the spine, we can see on the benign sector the exostosis, the osteoblastoma, osteoblastoma, aneurysmal bone cyst, osteochondroma, and the hemangioma. On the malignant side, we can see chordoma, chondrosarcoma, osteosarcoma, Ewing sarcoma, plasmacytoma, lymphoma, and metastasis. You remember that bone island is not actually considered as a bone tumor, but it is frequently seen in the skeleton, and the main fact that the exostosis may be mistaken for osteoblastic metastatic deposit, for example. And you know that inostosis or bone island is a sclerotic lesion that can occur in the axial or the peripheral skeleton. It is asymptomatic and is usually accidentally discovered. If you perform a bone scan, it may show warm uptake, and it is a sclerotic lesion in the range of 2 centimeters. One of the most pathognomonic features for the diagnosis of venostosis is the speculated margin of the lesion. And compared, if you remember, to the sclerotic deposit, the sclerotic deposit usually have a smooth margin. And the inostosis, being a sclerotic lesion, it will appear black in the T1 weighted image and also black in the T2 weighted image. And the differential diagnosis between inostosis and sclerotic deposits lies in the issues that sclerotic deposits usually show increased uptake on bone scan, but inostosis shows warm uptake. Sclerotic deposits are usually multiple, inostosis can be multiple, and the sclerotic deposits usually show a smooth margin, while the margin of the inostosis is speculated. Osteoblastoma can also be seen in the axial skeleton, and you know the classic appearance of osteoblastoma is the presence of an osteolytic lesion, and this lesion may contain a central area of calcification, which may be small or may be large, as you can see in this particular example. This lesion is painful, and 75% of the lesion are located in the posterior elements, the neural arches of the vertebral column, and 7% can be seen in the vertebral body. Then if you have a bone scan, this lesion is metabolically active, and it will show a strong tracer uptake, as you can see here in this particular example. Osteodyostoma is a radiolucent lesion or osteolytic lesion with a central area of calcification, and this calcium may be small and may be large. If you perform an MRI, you will see a low signal lesion in the T1 and high signal in the T2, while calcium will appear low signal in all pulse sequences. It will be located in the central part of the lesion. Then you came to the osteoblastoma, and the osteoblastoma is just a large osteoma. And this, of course, in imaging, and you know that osteoblastoma is a smaller lesion, and the osteoblastoma is a larger lesion, frequently occurs in the neural elements of the spine, is painful lesion, and is expanding. The lesion is surrounded by a sclerotic margin, and it contains calcium, and this calcium is distributed haphazardly within the lesion. It is not exactly in the central part of the lesion. Then you have the three radiological patterns of osteoblastoma. Number one, a radiolucent area with marginal sclerosis with no calcium content. And number two, an expanding lesion with matrix calcification. Number three, an aggressive lesion with bone destruction, soft tissue invasion, and matrix calcification. And this type cannot be usually discriminated from chondrosarcoma, and usually you need the help of CT-guided needle biopsy. This lesion is relatively an expanding lesion with destruction of the neural elements of the vertebrae and faint areas of matrix calcification. And this is a classic lesion of osteoblastoma in the left pedicle of the vertebra. There is expansion, there is bone sclerosis, there is matrix calcification in the lesion. And whenever you compare osteoblastoma with osteoblastoma, and then osteoblastoma is large in size, is an expanding lesion, it has a soft tissue component, and it may show multifocal areas of matrix calcification. Aneurysmal bone cyst is also seen in the spine, and you know this is a benign lesion with an expanding character, usually diagnosed by one of the well-known features, which is the presence of multiple fluid levels inside the lesion. Although fluid levels can be seen in other lesions, but they are usually pointing to the diagnosis of aneurysmal bone cyst. This is a classic example of an aneurysmal bone cyst in the lumbar spine. You see the lesion is involving part of the vertebra. The neural elements as well are involved with the classic appearance of multiple fluid levels. And osteochondroma is not a common lesion in the spine. It can be seen in the long bones, but sometimes you can see an osteochondroma in the spinal column, and this is an example. This is cervical spine, and you see an osteochondroma, which is a cartilage capped exostosis. The medullary cavity is continuous with the medullary cavity of the original bone, and the cartilaginous cap is usually better seen by MRI, especially the T2 weighted image. And remember that this cap should not exceed 1 centimeter in thickness, and the underlying bone is intact to consider the benign nature of the lesion. Vertebral hemangioma is one of the common lesions seen in the spine after the introduction of MRI. And then the classic appearance of hemangioma in the plain X-ray is what is known as vertical striations. Then you see this is the normal appearance of the vertebral body, and this vertebra is the seat of a hemangioma, and you can see the striation or the vertical strands running through the vertebral body, and this is because of the resorption of some of the secondary trabeculae with preservation of the primary trabeculae within the vertebrae, which gives this particular appearance. And this is also a classic appearance of the striated vertebra, and In the axial image, you can see this sign, which is salt and pepper appearance, and you see there is a dotted lesion involving part of the vertebral body. On MRI, you can see that the vertebral hemangioma usually appears of bright signal in the T1 weighted image and also of bright signal in the T2 weighted images. But you should remember that some of the hemangiomas can appear of low signal in the T1 and high signal in the T2 weighted image. And hemangioma can also involve the whole vertebral body, which will be then weaker than the rest of the vertebrae and is prone to fractures or compression. And this is an example. You see the vertebral body of L1 is the seat of a diffuse high signal in the T1 and high signal in the T2, and this is hemangioma. And you can appreciate that there is the compression fracture with depression of the superior end plate of the vertebra. And many times, if the hemangioma is of low signal in the T1 and high signal in the T2, it may be mistaken for spinal metastasis. And this is just an example to differentiate between the appearance of metastasis and hemangioma. Metastasis will appear of low signal in the T1 and it can show very faint increased signal in the T2 weighted images, as you can see here. But hemangioma will appear very bright in the T2 weighted images, almost reaching the signal intensity of the CSF in some times. The metastasis cannot reach this high signal in the T2 weighted images. And this is, of course, one of the differentiating points, but there are a lot of issues to differentiate both. I will mention them in a moment. Then we came to the malignant side of the lesions, and we start by chordoma. And you know, chordoma is arising from the remnants of the notochord. This tumor is usually midline, arising at the two ends of the vertebral column, more commonly in the distal part. 50% sacrococcygeal, 35% is pheno-occipital, 15% other sides of the spine. This lesion is destructive and it frequently contains calcific foci, which may represent actual calcification or remnants of the destroyed bone. And this is an appearance of chordoma in the sacrum. There is a big soft tissue mass infiltrating the sacrum with a sizable component inside the pelvis. Then one of the pathognomonic features of chordoma is its very high signal in the T2 weighted image, approaching the signal of CSF. And this is not for all cases of chordoma, but you can see it frequently. In the T1 weighted image, the lesion will show heterogeneous low signal. In the T2 weighted image, the lesion will has a very bright increased signal, which may approach the signal of the CSF, and after injection of contrast, the lesion will show heterogeneous pattern of enhancement. And this is the difference between chordoma, affecting the terminal part of the sacrum, very high signal, comparable to that of the CSF, and metastasis in the distal part of the spinal column, which in the T2 weighted image does not reach the signal of the CSF. Chondrosarcoma is not a common lesion in the spine. It can be seen in the ribs, it can be seen in the flat bones, but sometimes you can see chondrosarcoma in the vertebrae. The main diagnostic issues is to see a malignant mass with matrix calcification. Then signs of malignancy include bone destruction and soft tissue invasion. And here you can see a lesion which is arising from the spinous process of one of the dorsal vertebrae, infiltrating the back muscles with dense areas of matrix calcification. And here is also a chondrosarcoma in the anterior part of L4 vertebral body. You see a mass in the prevertebral area. The mass is invading the vertebra. The mass contains areas of matrix calcification, then whenever you are confronted with a lesion having a malignant characters with matrix calcification in a site that can be a location for chondrosarcoma, then you can easily predict the diagnosis. Ewing sarcoma is also not a common lesion in the spine. It can occur in the pelvis or in the flat bones, but you may remember that I have said that one of the main features of Ewing sarcoma anywhere in the body is the presence of bone sclerosis. And if you look carefully to this plain X-ray, and you can see that L5 vertebral body is diffusely sclerotic, and you know that this is a pediatric spine. And in MRI, you can see the vertebra is black in the T1 weighted image and also in the T2 weighted image. There is a soft tissue component anterior to the affected vertebra as well as posterior to it, infiltrating the spinal canal. Then you know that this is a malignant lesion, and in a child you may think of Ewing sarcoma. If you see a lesion like this in an adult, and you should think of metastasis, and the best way for further evaluation is to go to needle biopsy. Myeloma is one of the lesions that can frequently seen in the spine. It represents about 1% of all malignant bone tumors and 10% of the hematologic malignancies. Of course, there are many ways for the diagnosis, including the protein electrophoresis and the detection of monoclonal proteins in urine and the blood. Also, you can see some of the manifestations of myeloma in the plain X-ray and the CT as well as in the MRI. Then one of the common findings of myeloma in the skeleton is the diffuse osteopenia. Diffuse decreased bone density, which may be attributed to senile osteoporosis, for example. And this osteopenia may result in vertebral compression, and sometimes you see fractures. And this may be considered one of the features of myeloma in the skeleton. Also, you may see a solitary expanding lesion, which is known as plasmacytoma, or frequently you see numerous small osteolytic lesions of almost uniform size distributed through the vertebral bodies as well as the neural elements. And rarely you can see sclerotic lesions in cases of myeloma. And this is an example of plasmacytoma in two different patients. You see there is a soft tissue mass almost totally replacing the vertebral body and the neural elements, and the mass is osteolytic. There is no sizable extraosseous soft tissue component, and this is one of the features that may support the diagnosis of plasmacytoma compared to metastatic deposits, because deposits usually have a sizable extraosseous soft tissue component. This is a frequent appearance of myeloma in the vertebrae. By CT scan, and you got multiple small or uniformly small lesions affecting the vertebral body as well as the neural elements, with no evidence of sizable extraosseous soft tissue component. This is also an appearance. You see osteolytic lesions in the spine as well as in the pelvic bones, and you can also appreciate that the lesions are of almost uniform size. Then on MRI, you will see that in the T1 weighted image, you can see vertebral collapse at multiple levels. Of course, you know that the bone scan is usually negative, and the myelomatous lesions are metabolically inactive, and they are not usually detected by bone scan unless there is some activity in the lesion, which is usually related to complications like in cases of fractures, for example. And this is the appearance of multiple myeloma by MRI T1 weighted image and T2 weighted image. The lesions will show low signal in the T1 and the high signal in the T2. And you can see many lesions, numerous lesions affecting the vertebrae with multiple vertebral compression collapse. This is considered one of the stigmata of myeloma, as stated by some of the literature. Whenever you see that the vertebra is collapsed and the posterior border of the vertebra is encroaching on the spinal canal, and typically this border is convex, then if you see this appearance, this is not actually pathognomonic for myeloma, but it represents a malignant disease. You may suspect myeloma from this appearance, but the final decision will be left for the biopsy. And this is a case of myeloma, and you see the classic appearance mentioned by some of the literature, with multiple partially collapsed vertebrae protruding inside the spinal canal with convex posterior margin. Then we came to the most frequent malignant disease in the spine, which is the metastatic deposits. The metastases are usually osteolytic, but you may get osteosclerotic metastases, as those coming from the prostate or the breast, and you may get mixed metastases, osteolytic and osteosclerotic. The lesions will affect the vertebral body or the neural elements, and they are not involved with the disc spaces, as you know. The most common primary malignancies metastasizing to the spine are the lung, the breast, the prostate, the kidney, and the thyroid. One of the pathognomonic signs of metastasis in the spine by the plain X-ray is known as the pedicle sign. And this means that whenever you are looking to the vertebra, you can see the pedicle on the left and the pedicle on the right. The pedicle on the left and the pedicle on the right. But in this particular vertebra, you see the pedicle on the right, but the pedicle on the left is not there. And this is highly suggestive of metastatic deposit, especially if you see that at the level of the affected vertebra and you see a paravertebral soft tissue component. Then complete destruction of one of the vertebral bodies or partial destruction of one of the vertebral bodies in an adult is highly suggestive of metastatic disease. And also, if you see multiple sclerotic vertebrae like this, solitary sclerotic vertebra is for the differential diagnosis I mentioned. But if you see multiple sclerotic vertebrae, and you think of metastasis as first possibility. And this is the pedicle sign, and you see here that this pedicle is present, but this pedicle is absent. And before the era of CT and MRI, we used to have this myelographic examination, and you know that this pedicle is destroyed by a soft tissue mass which is compressing the contrast column, as you can see here. Then if you have the CT scan of the same case, then you see that there is destruction of the pedicle, part of the vertebral body, with extraosseous soft tissue component infiltrating the adjacent muscles. Then the CT appearance of metastasis will include osteolytic lesion, extraosseous soft tissue component, mixed osteolytic and osteosclerotic lesion, vertebral destruction with intact disc spaces, because you know that if the disc space has been involved, then you are in the side of inflammation, not on the side of malignancy. This is one of the important points considering metastasis in the spine whenever they are examined by MRI. I used to say that the most important and valuable pulse sequence for detection of metastasis in the spine is the sagittal T1 without contrast injection. In the sagittal T1 weighted image without contrast injection, and you see metastasis as focal lesions of low signal intensity multiple distributed through the vertebral column. Then if you have the T2 weighted image, then you can see you can hardly see the metastatic deposits because they will start to increase their signal. At the time the bone marrow will start to decrease its signal, then you got this iso intense signal to the bone marrow in the T2 weighted image. Then what happens if you inject the patient with contrast? Then metastases will enhance and you cannot see them after injection of contrast. Then we came to my conclusion, which is the best way for detection of metastases in the vertebral column by MRI is the sagittal T1 weighted image without intravenous contrast injection. Injection of contrast will not add any benefits, except sometimes it can better show the intraspinal soft tissue component if it is present. Then you see sclerotic deposits in the sacrum, and the low signal in the T1 and low signal in the T2 denoting sclerosis. There is a soft tissue component which is easily appreciated without injection of contrast inside the spinal canal as well as in the prevertebral area. After injection of contrast, the extraosseous soft tissue component will enhance, but I still believe that the most important pulse sequence for detection of metastasis in the spine by MRI is the sagittal T1 weighted image without injection of contrast. And metastasis can also involve the neural elements, and this is a good example of a huge metastatic deposit infiltrating the spinous process, the laminae, as well as the facet joint, with a huge soft tissue component projecting posteriorly. It will appear of low signal in the T1 and heterogeneous high signal in the T2. Contrast injection will not add too many advantages for the pre-contrast scans. Then, whenever you see a lesion like this in an adult, you consider metastasis. And the best way for further evaluation is to go direct for biopsy, either CT guided or ultrasound guided or whatever, but don't do upon a scan, don't go for any other investigation except for guided biopsy. And biopsy will confirm the diagnosis, and many times it will help you to identify the primary site of the pathology. And you remember my my words about the presence of a destructive lesion in the pelvis in an adult is usually suggestive of metastasis, and you should remember this. There is a destructive lesion in the vertebral column, there is destructive lesion in the iliac bone in an adult. If you don't know a primary malignancy, and this is suggestive of metastasis, and the best way for further evaluation is to go direct for biopsy. And if you see multiple sclerotic lesions like this, and you know these are sclerotic metastases, and you can have this reconstructed image by CT showing the levels of vertebral involvement. And you remember that sclerotic metastases have a smooth margin compared to inostosis or bone islands, which have speculated margin. Also, you see that this metastasis involves totally the vertebral body, the pedicle, the lamina, and this is not seen, of course, in cases of bone islands. The lymphoma of the vertebral column is seen in 2 to 3% of malignant bone tumors. Lymphoma represents 2 to 3%. And a lymphoma of the bone represents 5% of extranodal lymphoma. Is maybe in the form of Hodgkin disease or non-Hodgkin lymphoma. One of the common appearances of lymphoma in the spine is the presence of a sclerotic vertebra. And if, as I have mentioned, the vertebra is solitary, then you are in the differential diagnosis of one of three: either lymphoma or metastasis or Paget's disease. And this is a sclerotic vertebra, and then this is C5, and it is seen in the CT scan as well as in the MRI T1 weighted image. And this is a destructive lesion in the iliac bone as well as in the sacrum. Then you consider metastasis and go for biopsy, and after biopsy you know that this lesion is proved to be a lymphosarcoma. But this is an infrequent finding. Most commonly you can prove that this is metastatic deposits. Then we came to the intraspinal pathology, and we have the three locations: epidural lesions, subdural lesions, and intramedullary lesions. Then you know that one of the common extradural lesions is the disc lesion, disc herniation, disc bulge, disc protrusion, migration, sequestration. All these lesions can occur in the epidural space, and this is a good example of a massive disc herniation at L5S1 level. But actually you diagnose the disc lesion by its presence opposite or at the level of the disc. Then you know that if you see a pathology, bone pathology, with involvement of the disc in between, then you are dealing with an inflammatory lesion, as we have explained in the lecture of spinal infection. But if the lesion involves only one of the vertebrae or multiple vertebrae, then there is a history of trauma, and consider fracture with epidural hematoma, or you consider a neoplastic pathology, whether it is primary or secondary. And this is an example of a neoplasm, and this is an example of an inflammatory lesion. Then how can you judge that this lesion is in the epidural space? Actually, you judge the location of the lesion inside the spinal canal by the appearance of the CSF at the site of the lesion and the appearance of the cord. I hope you remember these two facts, very important. There is a lesion here, and how can you know that this lesion is in the epidural or in the subdural or inside the substance of the cord? An epidural lesion will compress the CSF and compress the cord. Then if you look to the CSF at the site of the lesion, you see that the CSF is compressed and the cord is also compressed. Then if you see this, and you know that this is an epidural pathology, and here is the cord is compressed and the CSF on the side of the lesion is also compressed, then you start to decide, is this lesion is single or multiple? If this lesion is single, and you consider the solitary metastasis or a primary neoplasm. If it is multiple, you consider metastasis or multiple myeloma. And this is an easy example. Here you see the pedicle sign. This pedicle is present and this pedicle is missing. Then you are dealing with a metastatic deposit compressing the contrast column of myelography. Then, if you see epidural pathology, how can you know that this is epidural? By the appearance of the CSF and the cord. And you remember the CSF on the side of the lesion. The CSF on the side of the lesion will be compressed and the cord is compressed. Then you are dealing with an epidural pathology. This is an epidural pathology. What are the possibilities? Epidural hematoma, epidural abscess, epidural metastasis. And you should know that these three lesions usually coexist at any site. One of them can be seen. I mean that if you can see an arachnoid cyst in the epidural space, then it is possible to see an epidermoid cyst, and also it is possible to see a dermoid cyst. If you can see arachnoid cyst inside the ventricles in the brain, then it is possible to see epidermoid and dermoid cysts as well. Then lymphoma is one of the lesions that appear in the epidural space without bony involvement. Then look at this example, and here you see an epidural pathology. And this pathology, how do we know that this is epidural? Because the CSF is compressed and the cord is compressed. Then this is an epidural lesion. And this lesion is enhanced after injection of contrast. And if you go through the list of the differential diagnosis, there are two main pathologies here, metastasis and lymphoma. In my opinion, if you see a lesion without bony involvement, consider lymphoma more better than metastatic bust. But if this lesion is associated with bony involvement, consider metastasis more better than lymphoma. Then here, you see a lesion in the epidural space. How can you know? The CSF on the side of the lesion is compressed and the cord is compressed. The lesion is not associated with bony involvement and it shows enhancement after injection of contrast. Then consider lymphoma more better than metastasis. And this is also a good example of lymphoma. This is an epidural pathology. The CSF is compressed and the cord is compressed and the lesion is enhancing after injection of contrast. Then you are dealing with most likely an epidural lymphoma. And this is also a case. Then you see an epidural lesion which is strongly enhancing. Here the CSF is compressed and the cord is compressed. Then in the T1 weighted image you see an intermediate signal which increases a little bit in the T2 weighted image, and after contrast injection and you can see increased enhancement of the lesion. Then if you see a lesion of bright signal in the T1 weighted image, consider these possibilities. Either it is fat, as in cases of epidural lipomatosis, or dermoid because of the fat content of the dermoid, or teratoma for the same cause, or subacute blood, extracellular methemoglobin, or melanoma, or this pantopic. This is a very old contrast material known as myodil, which is an oily material used to be injected inside the spinal canal before the era of CT and MRI. And this oily material may persist for years inside the spinal canal, and it can be seen in the epidural space or in the subdural space. Then here you see a bright lesion in the T1 weighted image, which is also bright in the T2 weighted image. And this is one of the lesions containing fat or containing blood. Then you can compare by other blood sequences like the fat suppression techniques. If this lesion is suppressed, then it contains fat, then you are dealing with lipoma, dermoid, or teratoma. But if this lesion is not suppressed, then you are dealing with hemorrhage, like the subacute blood or in cases of melanotic melanomas. Arachnoid cyst can occur in the epidural space. It will show CSF signal in the T1 and T2 weighted images, and this is an example of arachnoid cyst in the sacrum. It shows a high signal in the T2 weighted images, and if you have the T1, of course, you will see the low signal of the cyst. This is an epidural arachnoid cyst. How can you know that this is epidural? The CSF is compressed and the cord is compressed. Then the lesion is bright in the T2 weighted image, denoting that it contains fluid signal. You should look at the T1 weighted image for reaching the differential diagnosis. Thank you very much. Alhamdulillah Rabbil Alameen, and we'll continue after that.